Hello and welcome to those who've joined. We'll be getting started here in a few minutes.
You are muted.
All right. Well, hello, everybody, and welcome. Thank you for joining us for the Kidney Foundation of Ohio Learning Series. We have the honor of doing a joint learning series this morning with the Lupus Foundation of America Greater Cleveland chapter. So just some housekeeping things that I want to go over. So if we can go ahead to the next slide. A little bit about Kidney Foundation of Ohio. So we provide direct assistance to those with kidney disease. We provide and promote educational programming to the general public, renal professionals, patients, and their families. We service 32 counties in northern and eastern Ohio and have 2 affiliate chapters in Lake County and Summit County. We currently remain one of the only health and human services area agencies in northeastern Ohio, which provides direct dollars to patients to assist through the devastation of kidney disease. The foundation remains an Ohio-based organization, and all funds raised in Ohio stays in Ohio to help the patients. Today's webinar will last an hour. Questions can be submitted through the question and answer feature on your screen, either during or directly following today's presentation. And if time permits, we will have those questions answered. This webinar is being recorded and will be sent out after the session. And for future sessions, you can visit the Kidney Foundation website at kfoohio.org. By signing up for this webinar, your email has been added to the KFO email list, and you will receive information on upcoming events. This webinar has been approved for 1 contact hour through the Ohio Board of Nursing and through the Ohio League for Nursing. You will receive a certificate once you have completed the evaluation, and you should receive your certificate within a week of the conclusion of this evaluation. All evaluations must be completed by January 30th to receive your certificate. And I'm going to turn it over to Rita to talk a little bit about the Lupus Foundation of America.
Yes, good morning. My name is Rita Pichin. I am the lead patient navigator and a outreach coordinator for the Lupus Foundation of America Greater Ohio chapter. I want to thank the Kidney Foundation of Ohio and Dr. Provenzano for putting together this presentation and partnering with us. The Lupus Foundation of America Greater Ohio chapter started as a small grassroots organization in 1977, and there were multiple chapters in the state of Ohio, and they have all merged for now. In current day, we are covering the whole state of Ohio. We are an affiliate of the National Lupus Foundation of America, and we provide services for all people who are impacted by lupus. We're trying to improve their quality of life through research, education, support, and advocacy. So that's our mission. And we do this through multiple resources and services. I am just one patient navigator. We have regional patient navigators throughout the state. We do phone calls, we provide education. We also discuss services, try to help lupus patients live their best life. We have support groups throughout the state to provide education and support to lupus patients and caregivers. And support groups are virtual as well as in person. We do a new patient education class once a month for newly diagnosed lupus patients, but anybody can join. It basically covers what lupus is, the cause, who is impacted by lupus, diagnosis, treatment, and how to manage the disease. We have a number of assistance programs that is funded by the state of Ohio through the Ohio Department of Health to try to reduce barriers to care. And these programs include food assistance, medical copay assistance, transportation to healthcare appointments, and mental health counseling through our partnership with Signature Health. And we communicate a lot through magazines, through our podcast, Latest Lupus News with Suzanne. Living with Lupus is our quarterly magazine. We have a nightlight blog. We do community outreach, and we do summits and webinars just like this. So there is much support for lupus patients. And if you'd like more information, please contact us at 1-888-NO-LUPUS or send us an email at info@lupusgreaterohio.org. Thanks.
Thank you, Rita. A lot of resources that are available here in Ohio. So just some disclosures. As I said earlier, this webinar is provided with the Ohio League for Nursing. We maintain the responsibility of the records that we will send back to the Ohio League for Nursing for credentialing. There will be, the evaluations will be sent to them along with the attendees on this call today. If you are on this call and are calling in from a phone number, please be sure in the comment section to put your name so we know who you are, to make sure that we give you credit for this. To get your credit, you must attend 100% of this presentation, submit the evaluation. No commercial support has been provided for this webinar. And again, this is a collaboration with the Ohio, with the Foundation, Kidney Foundation of Ohio, and the Lupus Foundation of America, Greater Ohio chapter. So at this time, I would like to introduce Dr. Laura Provenzano, who is a nephrologist with the Cleveland Clinic and has expertise in lupus. So at this time, I'll let Dr. Provenzano go ahead and share her screen, and we'll go ahead and get started.
Good morning, everyone. Can everyone hear me?
Yes.
Yes. Okay, let me share the screen. Okay, there we go. All right, so good morning. Thank you, Jennifer. Thank you, Rita, for the invitation. Thanks to the Ohio Kidney Foundation and the Lupus Foundation of America for this opportunity. I'm very happy to be here today. I know there's a mixed audience, nurses, patients, maybe some other healthcare providers, some doctors. So I'm gonna try to give an overview of lupus nephritis. You feel free to post any questions, and I'm going to try to answer them at the end of the lecture, even in the middle if it's necessary. So just feel free to send any questions that you have. So that being said, I have one disclosure that I'm an advisor for a company, LifeMind Therapeutics, that works on immunosuppressive therapies for some glomerular diseases. So that being said, we'll start. So just to give you a bit of a summary of what lupus is, because lupus nephritis is one of the manifestations of systemic lupus. Lupus, as you may know, is an autoimmune disease. What does it mean? That there's our own body starts to react against itself. So there's a loss of tolerance to our own body, certain pieces, antigens of our body that will lead to an inflammatory response that will generate these chronic inflammatory systemic disease that we call systemic lupus erythematosus. SLE, that is a shorter name, affects mainly females and females of young age. And there's some genetic and environmental factors that are known to predispose to the disease, but the actual etiology is not very clear. So as we mentioned, lupus is a systemic disease that can affect multiple organs, if not every organ in the body, but mainly some commonly affected organs include the central nervous system, so your brain and your nerves, your mucocutaneous system, your skin, your hair, your mucosa, your oral mucosas, your blood cells, and it can lead to things like anemia or low white cell counts or low platelet counts, and characteristically affects the kidneys. In this figure, it mentions 20% of patients with lupus will develop kidney disease, but we'll see that it's actually much higher, the percentage. So how do we diagnose systemic lupus? There's different criteria, classification criteria that we kind of like put together to lead to this diagnosis that is a clinical diagnosis. And this is one of the most commonly used criteria, that is the Euler ACR from 2019. That basically, when as clinicians, we suspect that someone may have lupus when we listen to the patient and look at the patient. We have to kind of meet certain criteria to actually classify that patient as having lupus. So one of the first things that we do is to do some blood work after we suspect the disease. And one of the most commonly abnormal tests that we found in patients with lupus is what we call a positive anti-nuclear antibody, or anti-ANA. And that's an entry criteria for the diagnosis of systemic lupus, although not every person that is diagnosed with lupus will have that positive ANA. Once we have that positive ANA, our suspicion, we have a list of potential manifestations that we can look into the patient that have fever, low white cell count, low platelet count, seizures, oral ulcers, etc. And that if we reach a positive ANA plus 10 points of this classification, we can classify the patient as having lupus. Some patients, again, might not have a positive ANA, and we use different other blood work tests like low complements or an antiphospholipid antibody that may allow us to enter this criteria. And again, if we have more than 10 points, we classify the patient as having lupus. And then there's other ways that we can classify as patients, even if we don't meet those 10 points, that will allow us to put the name of systemic lupus. One important thing that I want to point is that having kidney involvement, it may be the single thing that you have in order to classify someone as having lupus, systemic lupus. So if you see here, when we do a kidney biopsy, if we have someone with lupus nephritis classes 3 or 4, that gives the patient 10 points already. And having that plus a positive ANA classifies the patient as having systemic lupus, even if there's no other systemic manifestations. So now we're going to focus on lupus nephritis. That is the topic of the day. And basically, lupus nephritis is the involvement of the kidney by this inflammatory disease that is lupus. And it is actually the most frequent severe manifestation of the disease. If you're going to have a severe manifestation, kidney involvement will be the most common one, okay? And up to 60% of patients with a diagnosis of systemic lupus erythematosus will develop along their lifetime a diagnosis of lupus nephritis. Because these patients are usually young females, they're usually diagnosed at a young age, around 20 to 30 years old. And if you are Asian, African American, or have a Latino descendants, your risk of developing lupus throughout your life goes up. How do patients present? Well, many patients will not have no symptoms at the beginning, and we will detect them only by doing a urine analysis and by the presence of either blood or protein in the urine. That might be the first manifestation. Occasionally, patients do present sick, what we call an acute nephritic syndrome, that will be a development of decreased kidney function, high blood pressure, maybe swelling, and an abnormal blood work. Or sometimes what we call a nephrotic syndrome, that is the presence of acute onset of like significant swelling that is associated with some other blood and urine abnormalities. Occasionally, the patients present with what we call a rapidly progressive glomerulonephritis. This is an inflammation that progresses so far that leads to a significant loss of kidney function very fast. And sometimes they present late stage because they have a late diagnosis with already established chronic kidney disease. What are the risks? Why it is so important to detect and treat lupus nephritis soon? Is because if we have one of these very severe inflammatory forms, then that could lead to end-stage kidney disease within 2 years. This is data from 1980, many years ago, when we didn't have as good treatments as we have now. And this could progress very fast to end-stage kidney disease. How do we prevent that? I'm sorry. What leads to that is we delay the diagnosis. So to prevent that, we have to diagnose early. An inadequate treatment, non-adherence to therapy, and flares, all of them will make this progression to end-stage kidney disease faster. And again, even treated patients have up to 30% of chances of progress to end-stage kidney disease nowadays. Probably maybe a bit less so now that we have better treatments. So apart from losing kidney function and potentially progressing to dialysis, what happens when you have lupus nephritis? Lupus nephritis is clearly associated with a decreased survival. This is the expected survival for someone who's born, and is a female, around 85 years old, like maybe 78 for a male. Having systemic lupus already gives you a lower expected survival. And again, if you have kidney disease, even lower, and if you have chronic kidney disease from lupus, even lower. So mortality is increased in patients with lupus nephritis, mainly when they develop chronic kidney disease from it. So detecting it soon, treating it soon, and leading to remission is very important. What risk factors do we have other than not detecting it soon and treating it appropriately for developing end-stage kidney disease or severe kidney disease? Patients of non-Caucasian race are at higher risk. Male patients with systemic lupus, or when we are diagnosed at a younger age, usually pediatric lupus nephritis is more aggressive. When patients have very active systemic disease, that's usually associated with worse kidney outcomes. And in African American populations, there are some patients that carry what we call a high-risk APOL1 high-risk gene allele that we are not necessarily testing for that, but if some patients would carry that and will have a higher risk to progress faster to end-stage kidney disease or advanced kidney disease. So early detection and treatment are essential to prevent this. So we have to frequently monitor urinary labs in patients with systemic lupus to detect early signs of lupus nephritis. And if we have any doubt or any suspicion that the patient may have it, we have to go ahead with a kidney biopsy because that's the only way to actually confirm the diagnosis. This is the most recent American College of Rheumatology lupus nephritis guidelines for screening of lupus nephritis in patients with systemic lupus. And if you can see here, for patients that have no known kidney disease, so you have lupus, you never had kidney problems, you should be at least having urine and lab tests for kidney function every 12 months, if not every 6 months. So 6 to 12 is a recommendation. Or if they have lupus and are having any sort of flare of any sort of kind, like skin flare, joint flare, nervous system flare, we should check for a potential flare in the kidney at that time too. Once we have a suspicion that the patient may have lupus nephritis, that there's urine, there's protein in the urine, there's blood in the urine, there's decreased kidney function, we cannot explain otherwise, we should really put in our minds that we have to do a kidney biopsy. Here the recommendation says proteinuria more than 5 grams in 24 hours, or a urine protein creatinine ratio of 0.5 or higher. Or if there's decreased kidney function that we cannot explain otherwise. But also sometimes maybe you have 0.4, but there's other things that make you think that maybe there's something that we may have to treat that will lead us to get to that kidney biopsy. So we shouldn't withhold the biopsy unless there's a real reason, very high risk of doing the biopsy for that patient. And if we already know that the patient has lupus nephritis and was doing great and suddenly flares, sometimes we may decide to do a biopsy there just to see if anything changed in that biopsy. Is there something new that the patient didn't have before that needs a different therapy? Or if the patient is already on therapy and is not responding as we wish or as we expect, maybe we decide to rebiopsy the patient to see what's going on, why the patient is not doing, there's something else happened, is the patient resistant, or is this all chronic kidney disease that we cannot fix with immunosuppression? So once we do the kidney biopsy, why do we do it? Because that allows us to classify the lupus nephritis, and the classification of lupus nephritis guides therapy. That's why it's so important that we have the actual classification. So classes 1 and 2, class 1 is actually when we look at the microscope and we see everything normal. But if we go with a special type of microscope and look at something called immunofluorescence, we can see that there's some immune complexes, some immunological reaction in the kidney, but has not led to inflammation yet. Usually those patients have no urinary manifestations, have normal kidney function. So most of the time we do not diagnose class 1 because we do not do a biopsy for these patients. Class 2 is a bit more, there's some inflammation. We can see it with the light microscope. That is the microscope we use more frequently to look at pathology. And the patient may have some protein, may have some blood, but it's very minimal. And if we have this form, we usually don't change our management other than the management for the systemic lupus. These patients may or may not be biopsied because sometimes they have a proteinuria that is like in the 0.4, 0.5 sometimes, and we do the biopsies at class 2, then we know we may not have to escalate therapy. But if we go and there's a class 3, that is that now we have much more inflammation, but it's affecting less than 50% of the kidney, then this class, as well as the class 4, that is more than 50% of the kidney filters, then we definitely have to start treatment immediately. We have something called class 5 that can appear alone or in combination with classes 3 or 4. That is a disease that is characterized mainly for protein in the urine, and that also needs a specific therapy, so it's important to know. And class 6 is the end-stage kidney disease. I mean, it's so much scarring in the kidney of that patient that there's not much we can do in terms of immunosuppression to save it, and we just work that patient up for maintaining whatever they have left and work them for transplantation or dialysis if it's needed. So that's what is lupus nephritis, how we diagnose it. And the important thing is that we know that it's serious. We know that it leads to end-stage kidney disease. We know that can decrease survival in our patients. So we got to treat it as efficiently as we can. So what are the goals of our therapy? First of all, we are to prevent kidney function loss. That's one of the main goals, and reduce the morbidity and the mortality of our patients by doing so. But also we have to think about the quality of life of our patients and that minimizing the side effects of the therapy. And once we achieve our goal, we have to decrease the risk of flaring because, again, lupus is a disease that flares. Any of the manifestations can occur multiple times throughout the life of a patient. So we have to use tools to prevent the flare because in the case of the kidney, a flare usually means loss of kidney filters and eventually progression to end-stage kidney disease or advanced kidney disease. So how do we treat it? For every person that has a diagnosis of lupus nephritis, even if it is a class 2 or even have a class 1 that we rarely diagnose, all patients with lupus nephritis and in general, all patients with systemic lupus should be on what we call an anti-malarial agent. In the United States, the most commonly used one is hydroxychloroquine or Plaquenil. And we know why do we have to use this in kidney disease patients, mainly because we know that they decrease the risk of a flare. And again, any flare that happens leads to kidney damage, so we want to prevent that. Any patient with kidney disease should be on what we call a kidney protective measures. And kidney protective measures include medications to reduce protein in the urine if the patients have protein, to control blood pressure, and they have to be on a healthy diet. And the specific therapy for the lupus nephritis will depend on the class that we see otherwise on the biopsy. Now, I'm going to try to show you what happened over the past 14 years because the treatment of lupus nephritis has changed significantly, mainly over the past 3 years. But over the years, we have learned how to treat it to prevent that very fast progression to end-stage kidney disease that I show you patients had in the 80s, right? So every person that has systemic lupus nephritis that is proliferative in kind, the class is 3 or 4, or significant class 5 with a lot of proteinuria, we used to start years since like many years, but these are the guidelines from 2012 compared to 2021, with a pulse of high doses of steroids followed by oral steroids plus another drug. Steroids alone are not enough. And the 2 drugs that we have been using over many years for induction of therapy, meaning to try to achieve remission to control the initial inflammation, are either cyclophosphamide or mycophenolate mofetil. This chart, I mainly put it there to show you that how we changed as we did more studies and understood better how these drugs work. We used to use like cyclophosphamide at different doses, intravenous or oral. You know, there were high dose protocols and lower dose protocols. And steroids would usually be at very high doses. And as time went by, we realized that we didn't need so much steroids to control the disease. So we started to cut from 0.5 to 1 gram per day with the pulses to, for example, 0.25 to 0.5. And the oral prednisone that used to be 1 milligram per kilogram of body weight per day was cut down to 0.6 to 1. And you'll see that nowadays it's even lower. But again, we realized we didn't need so much steroids to control the disease. And then studies showed that, low dose IV cyclophosphamide was as efficient for most patients as high dose. So the recommendation started to be as first line to use either low dose or mycophenolate. But the problem was that with that treatment, that is the treatment that was for the guidelines of 2021, still only maybe 40% of the most patients will achieve what we call complete remission. And even the ones that would achieve it would have a recurrence up to 66%. And still, despite that therapy, between 10 to 30% of patients will progress to end-stage kidney disease. Their survival would be decreased, mainly if they were beyond dialysis. So something was missing. I mean, we're doing better than in the 80s, but we're not doing perfect. So in this context is that multiple other treatments started to be studied. And there was some data that sometimes what we call multi-target therapy maybe was better. And that's when 2 main clinical trials happened that led to the approval of 2 drugs that are the 2 first drugs actually FDA approved for the management of lupus nephritis. And we're going to talk about the 2 of them. The first one, but before I do that, I want to tell you that what we realized is that all these studies that were done over the many years to treat lupus, analyzing the information from these studies showed that one of the most important predictors of long-term outcomes in patients with lupus nephritis was the degree of urine protein at 12 months. So patients that had a urine protein at 12 months of 0.7 grams or less in 24 hours did better long-term in terms of kidney survival and with that patient survival than patients that had more than that. So it became a goal of therapy to achieve that 0.5, 0.7 grams in 24 hours of protein by 12 months, 12 to 24 months. And these are kind of one of the guidelines that we use, the goals that we use for therapy right nowadays. I'm sorry, this is automatically moving. So at 3 months, we want at least a 25% decrease in proteinuria with a stable kidney function, 50% decrease at 6 months or more, and ideally less than 0.7 at 12 to 24 months. So here's where the new treatments come. And the first drug that we're going to talk about is belimumab, that is a drug that has been used for the treatment of systemic lupus for many years now, more than 10 years now. And the studies that were done to get it approved for systemic lupus showed some signal towards that was doing the patients with kidney disease maybe doing better if they were taking the medicine. So that led to the development of a clinical trial that was published in 2020 in the New England Journal of Medicine that basically studied the effect of adding this drug, belimumab, that is an monoclonal antibody against a substance that usually keeps lymphocytes, B lymphocytes alive and active. So basically, when you use this drug, the B lymphocytes end dying and they don't produce these autoantibodies that cause the harm. So they decided to see what happened if we used this drug in addition to what we have been doing now. So either in addition to cyclophosphamide plus prednisone, or in addition to mycophenolate plus prednisone. Do patients do better if we add this on? So that was a trial that lasted 2 years. And basically, it was a positive trial. So basically, their endpoint that was like, they wanted to achieve a certain reduction in proteinuria to less than 0.7, plus preserve the kidney function, plus lose low doses of steroids, plus not having to use a rescue medication. Did the patients on belimumab did better at 2 years? And here's the answer. So 43% of patients on the belimumab group had achieved that goal versus 32 on the group of patients that didn't receive the belimumab. These other patients either received cyclophosphamide or mycophenolate, so they received a standard therapy. So only 32% achieved the goal versus 43. And in terms of complete remission, that is a bit more stringent criteria, still 30% in the belimumab group versus 20% in the placebo group achieved that goal at the 2 years. So as you can see, not many people with a standard of therapy achieved the goal, not even with belimumab still, but they did better. Okay. I don't know if there's clinicians here, but one thing that we have to know is that belimumab works, but it doesn't work super, super fast. Here is, there's my cursor. The curve started to separate for around like 24 weeks. So not immediately. It's not something that you're going to see the difference right now. You got to give it time. Okay. So in terms of side effects, they were very similar. So adding another medication really did not add to the side effects, at least during these 2 years. And the most common side effects for both groups were infections, and respiratory infections the most common. And one thing that was always a concern for belimumab in the initial trials done for systemic lupus was the increased risk of suicide. That was a signal in the first trials that belimumab had, but it was not seen during this study. So there was no increased risk of severe depression or suicide in this study. So that's one of the new drugs that we have FDA approved for the treatment of lupus nephritis. The other one that we're going to talk about is a drug called voclosporin that went through different phase 2. They went through a phase 2 trial that allowed to the phase 3 study that we're going to discuss now. And that led to the FDA approval of the drug for the management of lupus nephritis. And again, similar story. This was published in The Lancet in 2021, but similar story. Can we do better than with standard of therapy, adding a third drug to the induction therapy of lupus nephritis? And in this case, the standard of care only used mycophenolate, did not use cyclophosphamide. So unfortunately, we do not have like randomized control trial data on voclosporin plus cyclophosphamide yet. But in patients with lupus nephritis that require therapy with immunosuppression, plus 3, 4, plus minus 5, they randomized a standard of care with mycophenolate plus steroids versus mycophenolate plus steroids plus voclosporin. And this study had this very important goal of they really wanted to use low doses of corticosteroids to try to minimize the side effects. So actually the pulse was only for 2 days, 250 versus 500 milligrams a day of solumedrol. And the prednisone dose was started only at 20 to 25 milligrams a day. You know, when we used to use like for an average patient between 50 to 60 milligrams, if we were doing like 1 milligram per kilogram of body weight, maybe 40, 30, 40 based on the 2021 guidelines. And now we're going down to 20 to 25 to start with. And they wanted to bring that down to 2.5 by 4 months. So really, really fast taper of steroids, not too much steroid exposure, and see if that would still lead to better outcomes. And this is very busy, but the end point of this trial was a complete renal response, or a urine protein to creatinine ratio of 0.5 or less at the end of the study. And the study was a shorter study, it was a 1-year study. One thing to take into account is these patients all have a kidney function that was not that bad. I mean, the belimumab group study had patients with worse kidney function included versus this one that they have to have a GFR of at least 45. But the important things here, again, this drug added on to standard of care did better once again. You can see here, this is the complete response at 52 weeks with voclosporin added on was 41% versus 23% versus placebo. Partial response was higher, 70% versus 52%. And one thing that is important here is that the time to achieve a complete renal response was only less than 6 months. I'm sorry, this moved, versus double for the patients that didn't get it. So voclosporin was, the addition of voclosporin to mycophenolate and glucocorticoids was achieved better outcomes than mycophenolate plus glucocorticoids alone. There were similar side effects. I didn't show you that, but the side effects profile was similar. And the important thing here was that they were able to use very low doses of corticosteroids without affecting the renal response. I don't know why it's not letting me move the slide. Wait a minute. Not letting me advance. Oh, there we go. Okay, so after this study, the investigators decided to see what would happen if we would keep the drug, because it's easy to start the medication, but it's hard to know when to stop it. That's kind of like part of the problem in lupus, at least. So they did better, but they were still on the medication. How long can we keep this medication on? How long do we have to keep it on? And one of the concerns that we have with this type of drugs called calcineurin inhibitors in kidney disease is that other similar medications such as tacrolimus or cyclosporin are associated in the long run with kidney disease themselves, because they lead to kidney fibrosis and
So it looks like we're having some technical difficulties. Give us a second and we'll see if we can get this back up and going. All right, so it looked like Dr. Provenzano was having some technical difficulties, hoping she's able to reconnect.
sorry, guys. Can you hear me again? This got disconnected.
Yep, we got you now. All right, thank you.
I apologize. Something got disconnected here. So let me share the screen. My screen is not sharing right now, no?
Not yet, no.
Here, share. Where's the PowerPoint?
So while you're doing that, it looks like we have a few questions basically in regards to like lupus flare-ups, remission. If I have the flu and lupus flare-up, what would my doctor prescribe for me was a question.
Okay, let me see, and give me 1 second. I'm
Yeah.
gonna try to see why it's not letting me share again.
So I
Share.
will respond that, it's very important, obviously, to talk to your doctor that you are seeing. Because I'm sure for Dr. Provenzano being on a webinar, it's hard to be able to diagnose or determine what's going on. So, I definitely encourage that you reach out to your doctor that you're working with, and I will turn it back over to Dr. Provenzano.
Okay, let's do. But I can, in terms of if you're having like right now a flare and flu, it depends on when the flu was diagnosed. Most patients that are immunosuppressed qualify for Tamiflu. No, so I mean, if so you can get the antiviral. If it's most of the time, that's what we do. Same thing with COVID. If you have COVID and you're immunosuppressed, we would give you Paxlovid as long as your kidney function allows. So for patients that are immunosuppressed, they qualify for antiviral therapy to try to shorten the time of the disease. That's one thing. Of course, if you develop a severe case, we might have to tweak around a bit the the immunosuppression to allow you to battle the disease, that because it could become a life-threatening infection on its own. No, so it's like it's never easy to treat an infection in setting of a flare, but the infection, if it starts to become close to life-threatening or organ-threatening, we may have to back off on the immunosuppression transiently and allow you to fight the infection and then bring it back up.
Thank you.
Okay, so sorry with all this, but the point here I want to make is that we have data now 3 years with voclosporin that basically the kidney function didn't drop at 3 years on the drug, and the benefits remain at 3 years using the drug versus not using the drug. Side effects were not worse at 3-year points, and they even stopped the medicine at 36 weeks and analyzed the data at 4 weeks without the voclosporin, and still the difference in benefit remained in favor of the patient group that used voclosporin. So we have 3 years data. So at least for now, if patients are started on voclosporin for induction of lupus nephritis, they can be kept up to 3 years on the drug based on the data that we have. Okay. And again, the things that, we know based on that data that at least the kidney function is not lost at 3 years, but the question is what's actually happening in the kidney, because maybe, I mean, the number looks the same, but actually in the kidney it's getting a scar anyway. That is what the calcineurin inhibitors will do over time, will cause this scar of the filtering units and so that's why they decided to do this like biopsy studies, only 26 patients, so really not too many, like 16 on voclosporin and 10 on placebo. And they compared the biopsies at the beginning, pre-treatment, and a rebiopsy. These patients received a kidney biopsy done again at 18 months to see if there was worsening of the scarring in the group that had received voclosporin versus the group that had not. And basically, they did not show a difference. So there were similar degrees of chronicity in the 2 biopsies. And of course, both groups had a better activity index because both of them had been treated. So they were better. Okay, so at least we have 18 months data in 16 patients that the biopsy didn't worsen in terms of chronicity. Okay. So because of all this data, now the new KDIGO guidelines of 2024 include in the induction of lupus nephritis classes 3, 4, ±5, the addition of, they can still say, well, you can use mycophenolate or low-dose cyclophosphamide as the 2021 guidelines set plus glucocorticoids, but you can also add on belimumab to mycophenolate or low-dose cyclophosphamide, or you could add voclosporin to mycophenolate as long as the kidney function is not severely impaired. So those are the new KDIGO guidelines that we kidney doctors follow for the management of lupus nephritis nowadays. So here again, this is which I show you the 2012, the 2021, and then now the 2024. Again, now, the induction is with a pulse of 250 to 500 milligrams of corticosteroids for 1 to 3 days. And again, the oral prednisone is now 0.35 to 1 milligrams per kilogram per day, depending on the case. No, most of the time we will start lower than the 1 milligram per kilogram. And again, we can use either a calcineurin inhibitor plus mycophenolate. Again, voclosporin is one of them. They also include tacrolimus as an option, and there's some studies in Asian populations that show that the addition of tacrolimus to mycophenolate also helped in a better outcome. We don't have that data in other populations that are not Asian, but we still use tacrolimus many times in patients that are not Asian when we don't have access to voclosporin. And then again, mycophenolate alone could be still there, cyclophosphamide alone could be still there, or belimumab plus mycophenolate or cyclophosphamide, so more options. But it's still not clear at that time, do we always have to start with the 3 drugs from the beginning? It was still like, well, it depends, on the case, on the physician. But just now, this year, just very, very recently, the summary of the American College of Rheumatology Lupus Nephritis guidelines came up. And in these new guidelines that are from the American College of Rheumatology, not the kidney side of the story, but still, they are recommending first-line triple therapy from the get-go. Based on all the data that we have, that patients will, have higher chances to achieving a complete remission without increased side effects, etc. So this is just coming out. The full guidelines are not out there yet. This is kind of the summary. Actually, class 5 lupus nephritis, that pure class 5, I didn't dig into too much. Most of the time most of what I discussed now had been class 3 or 4 plus minus 5. But when class 5 is alone, the treatment is kind of changing. Back in the time, like some years ago, if the proteinuria was less than 1 gram in 24 hours, there was an option of not even escalating immunosuppression above the Plaquenil or wherever the patient was taking for the systemic lupus in some cases. And we would treat definitely if it was more than 1 gram with immunosuppression as we treat in a proliferative lupus nephritis. But now it's more the tendency is to treat any person with like class 5 with lupus nephritis management. And in these specific guidelines, they recommend to use triple therapy from the get-go, even for patients with class 5 that have more than 1 gram of proteinuria diagnosis. So we're starting to be a bit more aggressive in the treatment because we think that if we achieve that outcome of proteinuria of less than 0.5, 0.7 at 12 to 24 months, we're going to give a better long life to the kidney and the patient. Still, the community is not 100% bought, I would think, on doing the triple therapy from the get-go for every single person, because some patients will respond to single therapy, to dual therapy, to prior standard of therapy fast, and we don't know if we're maybe using too much at the beginning in some patients that might not need it. So it's very hard sometimes to decide which one should go with the 3 drugs from the get-go versus not. Sometimes what we do is we start with 2, unless there's severe proteinuria or severe systemic manifestations that we would rather use 3 from the very beginning and give it 2 to 3 months. And if the patient is not going where we want, has not go into that 25% reduction, etc., we add the 3rd drug. But again, that might be changing very fast now with the new guidelines, and maybe most patients will be started on the 3 drugs from the beginning. So we'll see. So again, once we achieve the complete remission, it's very, very important. And I think this for lupus patients, that's the trickiest part, because one thing is to achieve remission. The other thing is to maintain remission. And it's very important to maintain remission because every time you flare, you lose kidney filters. Maybe your kidney function doesn't show it initially in terms of your creatinine, but we know that every time you have a flare, you're going to lose, kidney function. These are patients that have ongoing flares. They lose their kidney function much faster than the ones that don't have, or the ones that just have one. So again, age flare is a killer for the kidney, so we have to prevent them. And that's when it comes that we have to be on long-term preventive maintenance therapy, at least 3 years, if not 5. Those are the current recommendations. So when you get diagnosed as a patient with lupus nephritis, it's an issue, because it's like you are facing at least 5 years, possibly 5 years of therapy. That for young females that maybe want to get a baby, there are many things going on, they're studying, it's an issue, but we have to set that from the beginning to our patients, that it's very, very important we keep this maintenance therapy, and because then if we control it right, we gain a lot of kidney life and even survival for our patients, and we got to get that set in their minds from the beginning. So again, maintenance can be done with mycophenolate or azathioprine. We mainly use mycophenolate, but sometimes azathioprine can be used too, mainly when the induction was done with cyclophosphamide. And again, our goal is to avoid those flares that will accelerate progression to end-stage kidney disease or advanced kidney disease. A few words about like some new therapies that are coming. So this drug called obinutuzumab is currently undergoing a phase 3 study, so mainly a bigger study to see if it can be eventually approved as the other drugs were approved for the treatment of lupus nephritis, but it had a phase 2 study done that was published in 2022. That again, this is a drug that, I don't know if anyone heard about the drug rituximab, but it's similar to rituximab, but it's stronger. Causes a deeper depletion of B cells. And they in this study, they also added it on to standard of therapy with mycophenolate and steroids. And here you can see in the blue line, this is the percentage of patients that achieve complete renal response at 2 years. And in blue or purple is the group of patients that received the obinutuzumab in addition to the standard of therapy. And if you can see that at 36 weeks, well, even at 24 weeks, there's start to be a separation on the amount of patients that achieve the complete renal response. Again, the patients that don't, they're usually around the 20% of the patients only achieve complete renal response. It's really little. Here, they're pushing up to 40. That is more or less what we achieve with voclosporin in addition or belimumab addition. So again, it's this third drug usually increases the chances of complete renal response, but still we have a big gap. No, there of like 60% of patients that are not going to get it there. So, and just more recently, you might have heard about this like CAR T therapy. I think it's like very exciting new therapy that we have coming, that basically the investigators take blood cells, white blood cells, a specific type called T cells from the patient itself, and then they engineering them to be able to attack a specific thing in the body of that person that we think is associated with certain disease. And in this specific disease, with something that we think leads to the development of some of the lupus manifestations. So we re-inject these cells that are now active and ready to attack their bad cells on the patient that has lupus. And this is data of only 5 patients that received this treatment, because it is a treatment that requires some chemotherapy initially, kind of to wipe off the patient's immune system before they reintroduce these new cells. But it had pretty interesting results. The 5 patients that had refractory disease, they have been treated with multiple drugs and had not been able to achieve remission. The 5 patients after having this therapy went into remission that lasted for at least 3 months. And interestingly, they were able to be drug-free at least at the time of publication of the study, a median of 8 months with no therapy and no signs of remission. And the feelings that were kind of like resetting the immune system, removing those cells that are abnormally attacking the patient's body. So this is kind of, there's some studies that are enrolling for refractory lupus and refractory lupus nephritis. Some of them are in the clinic, in the Cleveland Clinic, if any patient or doctor is interested. And just to finish, as we saw before, many patients, even with the triple therapy, with everything, would not respond to therapy. And those are the patients that have higher risk of progression. And we go into this realm of what we call refractory lupus nephritis. And here we start to try whatever we have in hand to try to control the disease, because we know otherwise the patient will potentially progress to end-stage kidney disease. So apart from what we already spoke of adding the third drug that we talk, one of the common drugs that we add on to therapy in patients that do not respond to prior standard therapies, the rituximab, that is kind of the cousin of the obinutuzumab, and probably obinutuzumab is no stronger than rituximab. And they've been other things that have been tried that, there are case reports of use of other medications, that bortezomib, that is used sometimes for cancer, that also depletes one type of B cell that produces the antibodies. And there's been reports of bone marrow transplants and stuff, but there are definitely things that are done as heroic measures when there's no response to the therapy that we have available. So with that, I'm gonna finish. So just to summarize, lupus nephritis is the most common severe manifestations of patients with systemic lupus. And despite our prior or standard of therapy, many patients will still progress to an advanced kidney disease and a stage kidney disease and have increased mortality because of the disease. The later we diagnose it, the worse the outcomes. Proteinuria, the amount of protein in the urine, is the best marker of kidney prognosis as far as we know so far. And if we decrease that protein fast, we will have hopefully better kidney outcomes and patient outcomes down the road. There's new therapies. As we discussed, voclosporin and belimumab were approved over the past few years for the management of lupus nephritis, in addition to standard of therapy for classes 3, 4, 5, or combinations. And in cases of refractory disease, we have drugs like rituximab, obinutuzumab, multi-target therapy that we discussed, bone marrow transplant, and now we have CAR T therapy also available for patients. So with that, I finish and I take any questions.
Thank you, Dr. Provenzano. So one of the questions that was asked is, can pregnancy affect lupus nephritis?
Yeah, so pregnancy in lupus, there's some patients will go quiet and some patients will flare. We really don't know. But when you have known lupus nephritis, when you have having kidney disease of any kind, increases the risk of pregnancy-related complications, both for the mother and for the baby. And lupus nephritis certainly is in there. Lupus itself increases the risk of complications for patients, and depends on, there's different things that you may or may not have that make that risk higher. But if you have established kidney disease, so the risk that you will have a complication during pregnancy, having lupus nephritis, depends mainly on the state of remission of that disease. So if you walk into a pregnancy with active disease, your chances of a complication are very high. So that's why the recommendation is that you should be in remission from your lupus nephritis, in clinical remission at least, for at least 6 months before pregnancy is searched. You start to look for it. And you have to be at least 3 months on pregnancy-friendly medications, because pregnancy is contraindicated on if you are on mycophenolate, if you are on many of the anti-proteinuric medications such as lisinopril or losartan. Ideally, we should move you from those treatments that are the most commonly used for induction and maintenance to something like azathioprine or tacrolimus that are pregnancy approved, or approved. We know have data that are safe. You have to be on that regimen for 3 months, make sure you remain in remission, and then you can start looking for your babies. Because first, that's kind of the first thing that will minimize your chances down. Depends on how you walk into that remission. You can be in clinical remission, but still have decreased kidney function because your prior flares led to decreased kidney function. You may have persistent urine protein because there's a fixed cause of proteinuria, like scarring of the filtering urine, that you cannot get rid completely of your protein. The lower your kidney function when you start your pregnancy, the higher the amount of protein, the higher the risk of complications that you may have. And in terms of like some of the common complications that we see, preeclampsia risk rises, hypertension and urine protein level plus decreased kidney function increases that risk higher. You add it on as the more of those you have. Definitely you have a risk of developing hypertension if you didn't have it, or worsening blood pressure control during pregnancy. And for the baby, delaying growth, prematurity, and stillborn or abortion before the baby is born are also a risk during when you get pregnant with lupus. So every person is different, no? So we have to see each patient, and if you do walk into the pregnancy with decreased kidney function, then you have a chance to have lower kidney function after pregnancy. It can accelerate kidney function loss at pregnancy, but this is in any patient, no? Mainly when the creatinine, when your function is, the lower it is, the higher your chance you may have a loss of kidney function after the pregnancy. So there's risk, that being said, but if we do it planned, many times patients with lupus and lupus nephritis can have a successful pregnancy, but we have to do it planned and with a lot of monitoring. Occasionally, if someone is already very advanced in the kidney disease, they have a stage 4 kidney disease, that's kind of like the chances that you may progress to and maybe end on dialysis after pregnancy or during pregnancy because of a complication are there. So that's a question that has to be seriously discussed between the patient and the doctor to see, do we, depending on the age of the patient and, you know, the risk that they're willing to take, etc. Sometimes if you're really advanced, is it better that we just get a kidney transplant first and then you get pregnant? You know, it's just like every person is a different story.
Great. Thank you, Doctor. Well, we are out of time. I want to thank everyone for joining this webinar today. I know someone asked a question about patient groups. Just a reminder that the Lupus Foundation of America Greater Ohio chapter does do support groups for patients. And so I encourage you to please check out their website and their programs that they provide. Just a reminder that following this presentation, you will receive an email that will have the link to the evaluation, which will be done online. Once you complete that evaluation, you will receive your certificate within a week. And just to let you know that we will be doing a webinar February 25th, which is social media and Ohio nursing law. This is a category A credit for nurses and techs.
Wow.
It will be February 25th from 8:30 to 9:30, and the cost for that is $25. So if you are interested, you will be getting information on that, but you can always visit our website at kfohio.org. Thank you, Dr. Provenzano, for a fantastic presentation. And thank you, Rita, for representing the Lupus Foundation of America Greater Cleveland chapter. I hope you all have a good rest of the day, and we'll see you at our next webinar.
Thank